Gentlemen, my name is Nola Masterson. I'm the Managing Director of Science Futures, which is a management consulting and investment firm, 32 years old, and I am currently investing out of a fund called Portfolio Femtech Fund, which invests in things that women want to see in the world in the area of health tech, women's health tech. And it's an angel fund that's directed to encourage women to invest as angel investors in things that they want to see in the world. We have a very good panel. One of our members is sick, but I know that the panel itself can take over. I'm going to start from the far left and let them introduce themselves and tell you a little bit about their investment strategy. Go ahead.
Good morning, everyone. I'm Dianostics. Is this working?
Yeah, turn it on. Turn it on. Good button. You help with that? All right. We use
Maybe
that mic.
we use another one and then we have
Use that mic for a minute.
Yeah, let's do it. Just use this one. Okay. Yes, it is. Good morning. Let's start. Dianostics, all the way from Europe. I'm based out of Italy. I'm a venture capital investor. I have been such for 20 years. I have raised, managed, invested, exited. I think through my 6 different generation fund, over 80 plus companies all over Europe, US, and Israel. I'm co-founder of Panacas, which is a venture capital company with 100 million under management, investing in medtech, devices, diagnostic, and digital healthcare. Anything from seed to C round.
I'm Ted Driscoll, and I'm basically the managing partner of Digital DX. And what we're focused on right now is early detection of diseases before damage happens, which is very important, okay? Actually, 2 of my companies are actually in the room at the present time, which is very important to me. And basically, one of them can see Alzheimer's disease 8 to 10 years before dementia happens. Another one can see breast cancer that's only 4 cells. It's really important to basically detect diseases before they cause damage. And then also to figure out what's the right drug as well. So I think that's a key issue as well. So I'm focused on that issue. And basically, I've already done 17 investments and they've all been successful. Every one of them were basically, the pre-money valuation was around 50 billion. They're now worth 6 billion at this point. So they've all done very, very well.
Ted has the Midas touch. You might want to touch the end of his coat.
I always call a doctor right afterwards. I see a company and make sure the doctor reads it. That's the key issue. And whether it's a reimbursement code, whether they have patents on it.
And I'm OG. I'm a senior associate at Illumina Ventures. Our fund is one of these kind of hybrid funds. We spun out of Illumina in 2016. We're independent investors now, of which Illumina is an LP. But we do general diagnostics investing, mostly at the Series A stage. Our check size tends to be right around 8 million for that first check, and obviously we'll support our companies and follow-on invest throughout the lifetime of the company. We'll deploy maybe 15-ish million into the companies. We're not a diagnostics-focused fund. It's one of the focus areas for us. I'd say we do maybe 1 diagnostic deal per year on average, and our current assets under management, roughly $230 million. So of those, we split amongst therapeutics, diagnostics, and life science tools, which is why we end up just doing 1 diagnostic investment per year. We make about 4 on average per year. I'm happy to chat with people afterwards about different types of investment strategies, but we like to say we're a genomics-focused fund, but we're not tied to pure genomics and next-gen sequencing. We've made investments in a few diagnostics companies that just have to do with a good diagnostic strategy and have nothing to do with detecting DNA. So please don't be scared away by the Illumina name.
I love the Illumina name. They took the company I started, Sequenome, and made it better, faster, cheaper. And they brought down the cost of next-gen sequencing, and it's a fabulous company, and the venture arm is a really good arm. My fund portfolio, Femtech fund, actually is also invested in one of Ted's companies that's here today, Prime Genomics, and Robert Feldman's in the audience. And that company is analyzing microRNAi from saliva to detect early breast cancer markers. Saliva interrogates the lymphatic system, and as most people understand, breast cancer is spread through the lymphatic system. So it's a good catch. I'd like the panel, Diane, you can start again, to talk a little bit about generally the field of investing in diagnostics and what's important. Is it regulatory first, second, third, or is it FDA clearance?
Regulatory or regulatory, which is very important indeed. So let's start with what we invest in. When we invest in diagnostic, we invest in anything that makes sense. There is no restriction. For something to make sense, there has to be a medical need, but also there has to be a lot of caution in evaluating what is the current standard of care. And this is something I really recommend to companies, especially those that are founded in the early days, founded by scientific teams, because not all the time they are very focused on the science, not all the time they look at what the standard of care process and the patient journey looks like, and they can't really translate their numbers, which maybe look very good in sensitivity and specificity, into a process that would be based on predictive values and positive predictive values and negative predictive values, strongly affected by what the process looks like. And this is something we totally immediately jump on when we are reached by companies in diagnostic. Tell me what's the process, where you think the innovation we're trying to bring, and what the what the predictive values are. And it's not always, we don't always get an answer immediately. It's like something companies are not paying a lot of attention to, and then when they come back, sometimes it's very exciting, sometimes they themselves find out that there is no real fit in today's standard of care process, so there is like no reasons to exist and innovate in that specific space, which is sometimes can be very disappointing. So this is what we look at when we have to consider a diagnostic very closely, and it's really the focus. And now back on the question, the regulatory, of course, we come from, I come from Europe, where the regulatory is quite different and can be very generous for companies, like allowing, for example, regulatory to be cleared retrospectively in lots of cases, which is very good and very attractive, because it doesn't require a lot of money. I sometimes I can bring that type of experience to companies and recommend that this is where they start from, to be on the market very fast and very soon.
So you would advise a diagnostic company to get the regulatory umbrella done in Europe prior to coming to the United States?
It very depends on what's the claim. If the claim is prognostic rather than diagnostic, so I'm trying to address an event that has to happen in a certain number of years, and for example they are getting something not in vivo but blood-based, they can certainly do the clearance in Europe based on samples that have been frozen somewhere in some hospitals, some research centers, without having to do a prospective trial, which is very, very, as you understand, I mean, it's an amazing, it's very interesting. So sometimes, in some cases, when the value is prognostic, I would recommend to start from Europe.
So prognostic meaning something that goes along with the therapy?
Right, or no, something that goes along with time. I mean, that is an information that is anticipating something that would happen in Ted mentioned 20 years in advance. So how do you prove something prospectively in a prospective trial? You have to wait for 20 years for this to happen. Well, if you can do that retrospectively, which is allowed in Europe and the current regulation, you can just take blood samples if they are available. If it's, for example, blood-based technology, it's not in vivo, of course. or saliva samples if they are stored somewhere, or which is more unlikely but possible, and see if that specific value was there 20 years before. It also depends on the technology, of course, and get clearance on the claim, on the diagnostic claim in Europe with that. So it can be very advantageous.
Diana brought up a good question, maybe you could answer, Ted. How easy is it to get samples to do clinical trials with for the new phase of diagnostics?
One of the big problems, I think, right now with medicine is that people kept taking blood samples in order to figure out what was going on, whereas saliva is much easier to capture and urine is much easier to capture. And they're also showing you whether you have a kidney problem or whether you have a breast cancer problem or a pancreatic cancer problem or something like that in saliva or in urine and things of that sort. So that's one of the things I think is very important. One of the things that's happening, I think, is that the word diagnosis is changing. It used to be what was the damage already in your body. Now it's diagnosing a disease before it causes damage and what is the right treatment for it. And that's what's happening, is that the world is changing very fast. I'm reading a book right now called Ending Aging by Aubrey de Grey, and he's literally saying in 50 years people are going to live 1,000 years. I'm not sure I want to live 1,000 years, but on the other hand, this is what's happening. We're changing everything. We now understand the genomics, we now understand the epigenomics, and we are going to basically start finding out that maybe we're using epigenomics to turn off a bad gene or something like that. That's what's going to happen in the next couple of years.
Can you comment on that, Noel, since you're in Florida?
So one of the challenges that we're seeing with some entrepreneurs coming in with especially prognostic tests, there are different therapeutic areas where even if you detect early, there's no real intervention, and I think people kind of fall into the trap of thinking if I know earlier, it's better. But it's kind of like ApoE for Alzheimer's. You can know your genetic mutation, your likelihood to develop Alzheimer's. But it turns out 80% of people don't want to know that information because there's nothing you can do. If you're going to get the disease, you'll get the disease. And that's something that we make sure we stress test with business models for entrepreneurs is if this is a diagnostic, what is the actual utility, as Diana, you mentioned, and how does that actually add value to the healthcare system? Now, it's a little bit easier for us because we're almost specifically and strictly sticking to the US for the initial markets, and we know even in this broken system, at least there's a process in place, and we look at that. But that, one of the main key things is just making sure that there is utility and someone benefits, because navigating who's going to pay for what, who sees the benefits of what, especially in the US, you could be saving someone a lot of money, but it's not going to be the person paying for the test, right? And so all of these factors kind of come in together, and you have to make sure that you're testing for something that someone wants and can actually intervene.
Before you got into Illumina, you were LKE Consultants.
Yes.
No, what did you do at that consulting company that led you to having some insight into the diagnostic space now?
I was a management consultant before. LKE Consulting is a management consultancy that works mainly with pharmaceutical companies, but also with tools and diagnostics players. One of the big trends over the past, I'd say, 5 to 10 years, especially with companies like Foundation Medicine, Garnet Health, et cetera, has been the rise of more precision and personalized care, just based on biomarkers, genomic or otherwise. Some of the projects I worked on there were in conjunction with pharma, as well as some of the largest diagnostics players. There's only a few large diagnostics players, but the largest guys in the field trying to formulate a strategy for how they can work together collaboratively rather than separately to add holistic value to care for patients. And that's been a huge strategic challenge for a lot of companies. A lot of diagnostics companies have struggled with that, with pharma eating a lot of the benefits, diagnostics companies doing a lot of the work. But I think that was a story maybe a decade old, and they're starting to figure out how to work together in a mutually beneficial way, also in a financially beneficial way.
Ted, you want to speak to that?
I found that medicine is basically becoming molecular. It used to be looking for lumps and x-rays and things like that, but now it's becoming molecular. They're doing liquid biopsies, They're seeing markers that tell you what the disease is and things like that before it's actually caused damage. And I think that's one of the fundamental things about medicine right now, is that someday we're going to start catching diseases before they've actually done any damage and then cure them right away. And that's what's happening. So the world is changing very fast. It's one of the biggest problems that we have, is that basically we used to basically detect diseases when we saw a lump in an x-ray or something like that. Now we're going to start seeing it with liquid biopsies and seeing markers floating around in your blood or your saliva or your urine or something like that. I wouldn't be surprised in a couple of years if I don't have a toothbrush that basically has a little red light on the end that goes on when it sees something in my saliva. This is what's happening. The world is changing very fast. We're moving toward wearables now also. Right now. My son works at Apple, for example, and I think he designed the Apple Watch. And the Apple Watch can already now see all kinds of things about your body and things like that. And it can maybe even call my doctor and tell my doctor this person just missed a beat or something like that. So that's what's happening. The world is changing very, very fast.
Do you see that same change in Europe, Diana?
Yeah, sure, indeed. It's so fascinating. There's always a question when we talk about screen population. There's always a question of how healthcare system or insurance, which have a different point of view, can bear cost associated to it. So that is, I mean, there has to be, it goes back to my comment on the process. It has to be carefully thought. What do you do with the positive? What do you do? What do the negative is? What would you do with the positive, and how many false positive end up in a population, and what's the next level? How many false positive are you sending for at that point? There may be a more invasive and more expensive check, which is something that cautiously everyone will have to take care of. So I think we always think in the wrong process. So it's fascinating being checked, continuously checked, but we have to consider associated costs, and not everything makes sense, unfortunately.
Given that we have an audience of entrepreneurs here, how would each of you like an entrepreneur to come to you presenting an investment case for their company? Well, what's the steps for that?
Every time I see an entrepreneur who gives me a pitch, I immediately call a doctor, a specialist in that area, and say, do you need this? This is important, okay? And also, do you see this patient every week as opposed to seeing them once a year or something like that? And then is there a reimbursement code for it? And do you have patents on it as well? So that's one of the key issues, is basically find a disease that is a serious problem for doctors to deal with and catch it early before it's actually caused damage to any kind.
Can I comment on that, Ted? Sorry, because we make it a little bit live, because I slightly disagree with that. Because when it's about diagnostic, it's a lot about statistic, where doctors not necessarily are on top of. Plus, I can't remember a single call to a doctor saying, I have this new biomarker that detects a new thing. Do you like it? And him answering, no. Do you need it? And he answering, no. I can't remember any call. Of course they want to know more. Then, next question, and I'm sure you do the same, that to the same doctor would be, yeah, hold on a second. Who would you test with that new test? And what would you do exactly with the information? And when you dig into that type of questions, well, all of a sudden they may be, well, they may be more embarrassed, and not necessarily, because their excitement of having new information about a patient is always there. New biomarkers, always good reaction. That's really an equation. But then, I mean, thinking of more and more, and this is sometimes challenging and annoying for the doctor who says, well, I am the doctor, I know how to take care of my patient, not necessarily wants to answer, but if you challenge him and saying, well, and then, I mean, it's fascinating to know this new thing about the patient, what would you do with, what's the actionable? They get annoyed, they say, I take care of it. And then that type of questions are really, it's not only do you need it, because you need it, normally they like to have it. There
just wanted to react to that real quick. So if we go into diligence with a diagnostics company, usually we're calling roughly a dozen different doctors. And as I'll give you an example. We were in diligence with an infectious disease diagnostic company maybe 6 months ago, something like that. Sometime last year we were doing diligence. And I spoke to more than 12 doctors, and guess who I talked to? I talked to 2 intensivists, 2 ID specialists, 2 ER docs, and a handful of hospital administrators who are the actual ones paying for all this stuff. And they all say very different things. I think that's one of the key things that thoughtful entrepreneurs have that are different from slightly naive entrepreneurs is they understand how the healthcare system works and the different stakeholders that are involved in the process of adopting a new diagnostic test. Just because one person likes it doesn't mean that everyone likes it. And doctors have egos. Everyone has. I have an ego too. Everyone has egos. They all clash with each other, and there are kingdoms, sub-kingdoms within hospital systems for which, for example, an intensivist might say, I need these results, and then the actual ID specialist says there's nothing you can do with it. You don't need that, and then the test doesn't get adopted. So to the point of you have to be very thoughtful when you talk to the doctors. You also have to be very thoughtful who you're talking to and make sure that you collect information from all the stakeholders, just because that's the healthcare system that we live in today.
It is. Question from the audience?
Yeah, you. Go.
Yeah, my question was, I guess, about the tension between, on the one hand, you have new technologies and possibilities for point-of-care diagnostics, for example, that could potentially be dramatically cheaper than what exists today as standard of care. And at the same time, you have the interest of investors who are pushing to maximize the margins. And I found, the tug of war to be challenging in terms of if you want to go for technologies that will dramatically cheapen cost of care, and the point of view of investors who are less interested in making it cheaper and more.
Is there a question there?
Well, the question is, how do you deal with the tension?
How do you deal with the tension between the investors who want to develop a product that has high margins and the ability to lower the cost of care in diagnostics? Is that the question? Analyst, do you want to take that?
I think it goes back to the health economics associated to a certain information being made available at point of care. If that brings a lot of value to the process, then I think it's good. It's normal to go for high pricing because it compares with that, and where investors and companies need to make profits. I think it goes back to basic and fundamental of what we do, and if we can afford high margin, because the pricing is acceptable given the health economic associated to it, why not?
One of the things that's happening right now is that everybody is slightly different. Everybody's got personalized medicine now at this point, and that's one of the biggest issues at the present time. I can tell you, I took a test once that told me which 89 different drugs worked for me and what was the right dose. It turned out Tylenol doesn't work for me. I had already taken Tylenol for headaches, and it had no effect, and things like that. And that's the company that I basically invested in. I sold it for $410 million after investing in it for a $3 million pre-money valuation. And it's one of the things that's very important is that you have to understand what drug works for you, what's the right dose that's going to work, and whether it's going to actually cure your problem or not. And this is what's happening. Everybody's slightly different. And not only that, basically if we're sitting there or going out into the beach, sitting in the sun or something like that, our epigenome can get changed by the solar radiation or something like that. So this is what's happening as well, is that things are changing very fast. And this is one of the biggest problems we have.
Question over here.
So when you answer the previous question about you talked about the payer, you talked about the doctors, you talked about all of that, but you didn't talk about the patient. And when you evaluate the new opportunity, and of course nowadays it's inconceivable that the patient really drive everything. It's 23andMe, it's foundation that drove how we look at cancer. It's the first question perhaps that you should ask all your investors is, can you stick it on social media such that the patient really would drive that? You would go to the physician and say, I need a foundation medicine. That's how they actually did it. Because today it's inconceivable that nobody would not give a foundation one or I don't know, Gardens 360 or whatever to their patient. And it was driven not because of payers or physicians. The physician were dragged into the picture. So you should always ask yourself, is it a test that would fit that such that I can actually ratchet it up through the media to such that they will do that?
There's a PR component then to getting the personalized medicine.
It's democratizing medicine, which is all diagnostics we are the first one to actually do that. Diagnostics is the only field that you can democratize for real, because the price structure is such that you can actually tell people, and it's something that you typically address people before they know something. So it is not something after they know. You're not really telling them, oh, well, you need a $100,000 drug. That is a physician type of a question. You're asking yourself, is it a test something that I need every year? This is something that you can address to a patient directly.
If I could quickly comment on that. In the US at least, people aren't used to paying for anything in healthcare. And for foundation medicine, speaking as a VC and knowing Mike Polini, who was the CEO of Foundation Medicine, that was heavily subsidized by first VC dollars and then Roche dollars to have patients ask for something, and that's something that most companies can't do, right? Because a foundation test was not covered by any insurance. The company was absorbing the cost of running things to drive adoption, and that was more of a physician play than a patient-driven play. I think there's definitely a space for what you're saying, but it's you have to be quite careful, because when you have the customer, who is the patient, decoupled from who's opening your wallet to pay for the actual testing, you have misaligned incentives sometimes, and it doesn't quite work out in the same one-to-one ratio that you hope it would work out. As in consumer tech, for example, it's an issue that I don't have a great solution for. I think smarter people in the room that are entrepreneurs probably have a better idea for how to get past that. But I think that's also, it comes to who cares if something's cheaper if the person that you're selling to doesn't benefit from the cheaper test. That's something you have to consider, and it's just the way that we're set up. I'm not saying it's a big system, it's a system that we would say.
I think what's happened is that medicine's become molecular, and it's a lot easier now to determine whether the molecule is in your blood or your saliva or your urine than it is to have an MRI scan that costs like $1,000 and things like that. So I think medicine's becoming cheaper as time goes on, and that's one of the key things. I went down to San Diego and had my genome sequenced by Craig Venter, okay? And basically I found out that all of a sudden I was 3 inches or 4 inches taller than all of the rest of my family. And I couldn't understand why. It turned out, I think, that the sun actually changed my epigenome, and it suddenly made me 4 inches taller than the rest of my family. This is what's happening. We're basically living in a world where we're not even standing still. We're changing as time goes on.
And this is especially true in oncology. So a lot of the diagnostics are in the area of, is the cancer drug working for this particular cancer, which is really where you get the precision medicine. Do you want to talk about that a little bit more?
Sure. I think that was something that Diana said earlier that really resonated with this topic. It's very statistics driven when it comes to that. I definitely agree. I think Ted's insight about medicine becoming molecular is definitely true. But as things move into molecular testing, I'd say mechanisms become more murky just because we're not as smart as we think we are. I'm a biologist by training. I think a lot of people here are probably biologists by training. And it turns out we don't know anything. Every 10 years, every science paper is basically disproven, right? So I think that the only way that we really see kind of benefit is using hardcore statistics and making sure our experiments are run correctly in patients, and that's a big part of cancer diagnostics. And if you look at GRAIL, they raise a ton of money to pay for tens of thousands of patients because you need that statistical power for what they're trying to do, and I think that's going to be a trend. Obviously, skill can be quite different depending on what you're doing. Braille is doing its own kind of big thing. But at the end of the day, it comes down to statistics.
Question here.
So my question is more about the delivery of the product and the regulatory situation. So do any of you have restrictions or inhibitions about investing in a lab-developed test through a CLIA lab versus a test that goes through the FDA?
CLIA lab versus FDA-approved lab?
Right. No, not FDA-approved lab, FDA.
IVD.
It's the regulatory test.
Yes, right. No, actually, no, there's no restriction. We think, and since there was success stories, I mean, foundation was mentioned, and lead out of the clear lab type of model. So we're absolutely open to that. We do consider that, I mean, there is an associated risk to it because we know FDA has been very nervous about it for some time, trying to address, haven't done it yet. Will it be done at some point? Not sure. At the same time, I do go back to this idea of clearing the product elsewhere as well at the same time. And because sometimes, again, FDA requirements of prospective trials can be very heavy. But if the product can also be cleared somewhere else, that in Europe or in China, in big markets as well, that would somehow mitigate the risk that of being without FDA approval on the market.
I personally think the FDA is becoming obsolete because everybody's slightly different. Some people take a drug and it works. Some people take a drug and it doesn't work. And that's one of the biggest problems right now, is that I think the FDA used to think that everybody was exactly the same, and that was what was going to happen, was that drug was going to work for them or not work for them. I'm not sure you guys have all seen this article a couple of weeks ago. There's an anti-arthritis drug called Enbrel, and it turns out that 500,000 people have taken it, and not one has developed Alzheimer's disease. So we're going to find out all of a sudden that drugs have different effects that we didn't even know about. And that's one of the biggest problems, is that basically we're starting to understand now that drugs have different effects in our bodies and things like that.
Yeah, I go back to what Obama said when he was president. He said, who would want imprecise medicine?
So if you can sell it to the doctors.
Pardon? Did you have a question?
If you can sell it to the doctors, right? The approval path.
Can you stand up? I can't hear you.
I'm talking about the approval path.
The approval path?
Yeah, the doctors are using it and ordering it, then the regulatory path is less relevant. Because what's relevant is what's good for the patient.
So we can't
We
hear
cannot
you.
hear you. You have to stand up.
Oh, there's no question, never mind.
Well, just another question.
Oh, okay. Yeah, I mean, regulatory approval is what is important to be able to use any diagnostic. And that is always the issue when an investor is presented with a new diagnostic opportunity to invest in, is what is the regulatory path? And how many patients do you have to have? And what are the statistics about how many false positives and how many false negatives? And maybe the contaminants could comment on the use of AI in getting to those statistics.
Yeah, shortly.
Okay, go ahead.
The use of algorithm, do you want to put it this way? Yeah, indeed. I mean, diagnostic is most of the time is about treating a big set of data, and not necessarily it's in real time, not necessarily it's really AI-based, but algorithm treat those will do certainly make sense, and they help to get to conclusions. So it's very good, and it helps us also to believe that the business is twice protected, not only by patent patents, but also by an associated software, which most of the time brings some value also in protecting the business itself.
AI is getting smarter than humans. In the next 5 to 10 years, it's going to be smarter than humans. And that's what's happening, is that AI can suddenly deal with large amounts of data much easier than humans can, because humans have a certain size brain, and that's all they can do. On the other hand, AI is getting smarter and smarter and smarter every single day. And that's one of the biggest problems is that we're dealing with. I'm pretty sure that doctors are going to use AI all of a sudden to figure out what's wrong with you or something like that. And that's what's going to happen in the next 5 or 10 years. Because I can remember AI, my son got his degree in AI at Stanford and things like that. And he was saying at the time it wasn't that smart, but now it is. Now it's getting smarter and smarter and smarter every single day. As processors get faster, memory gets bigger, and things like that, AI is going to actually have a huge effect on medicine. And I think that's what's going to happen in some point.
Just a quick comment. Actually, I think all of our diagnostics investments have been LDTs, not IVDs, because I mean, a lot of times true technology is hard to get, or like new innovation is hard to get through the FDA quickly. They look at exact sciences, it took them about 20 years to get to their test. They're huge behemoth now, but you know, there's some test and it worked and people liked it and it was totally fine. On the AI question, what we usually see in terms of algorithm development, it's for the actual test, and you lock down your algorithms at some point, and then you take that and then you run your either retrospective or prospective studies, but with your lockdown test. We're not using it to like evaluate how different patients respond on the fly, because I think again, controlled experiments to drive whether or not something is statistically significant or not, I think is quite important. And so, most of our companies actually use at least machine learning, and some of them even deep learning in their actual diagnostic protocols, but then they get locked down and say they have enough training and they've locked down on the test, and then that set test gets tested in the same way across a large population of patients.
One of the problems in diagnostics over the past 10 years has been the evaluation of the company. And it seems that the process of going public doesn't really add value to past 100 million for a diagnostic test. Whereas if you have a drug, it can be billions of dollars of valuation. Would you like to comment on that?
I can do a quick comment on that. Blockbuster drug brings in $1 billion a year. Blockbuster diagnostic does not. And so I think that's the main reason why the valuation price is driven that way. And drug pricing, who knows where that's going to be in a few years. It's an election year. Everyone's talking about it. They're talking about it every other election year, and nothing's happened. So I'm not quite sure if anything will actually change. But I think that's the main driver at the end of the day. And if you have a drug, the way we look at investments in therapeutics versus diagnostics, it's a little bit easier sometimes with therapeutics. There's a larger chance that things will just not work because it's biology, and again, we don't know anything about biology really, so you got to test things in patients. But the general rule of thumb is if you have something that works, you will make money from that drug because it will directly impact that patient's life. It's much harder to make the case with diagnostics. You have to have the healthcare economics. You have to satisfy many more stakeholders, and I think a lot of those feed into pricing what you get for your innovation.
But if you do, there is a business case. We have seen a few.
Yeah.
Grail is one example of a very, very, very good valuation, very generous valuation indeed in diagnostic. I don't want to mention Dianostics because of what happened after, because of course, sorry for that. But indeed, when it was valued by investors for the value it would bring, it was very generous valuation was given. Exact science is another very good example. So I think there are very specific cases where diagnostic can make very big and interesting as in therapeutics. Case. I fully agree that you have to check all the points and all of these, but potentially be.
To continue on the same thread, actually, is the last bio. It was so clear that almost diagnostics, we don't have to do anything. They'll just jump off the cliff. Most of the half of bio was to celebrate CAR T. The other half was how to convince Medicare to spend $1 million per patient. So you multiply how many people on stage 4 cancer times $1 million, you realize that they jumped off the cliff. So the whole idea is forget about precision medicine, which is to find patient later on and then stick him with CAR T and precision therapies and all of that. The whole idea is eventually would come to the common sense approaches that the salvation has to come from early detection, and it has to be inexpensively early detection. And maybe with AI they're gonna filter people to common sense tests, and maybe some cheap IVD, and whatever, some reincarnation of Grail that's not gonna cost $500, or whatever it is. So the point is, how do you convince your LPs to put money in this? Because clearly the time is on our side and not on their side, because they already bankrupted the whole bank. I mean, that's clearly not going to be the solution, expensive therapy.
It's true.
And I'm singing to the choir, I know that.
But there's another angle to diagnostics, and that is at-home diagnostics. And I think there's an opportunity there for people who want the privacy of analyzing their own ability to know if they have sexually transmitted disease, or if their urinary tract infection is under control or not. Panelists want to speak about that?
Well, one of the things that also happens is if you go to a Thai restaurant, your microbiome is different the next day, and it may turn off a drug that used to work for you, and things like that. So that's also one of the problems we face right now, is that we eat very different foods all the time. The fact is we all carry caveman genomes, and cavemen did not eat different foods, but we do. If I go to a Thai restaurant tonight, suddenly a drug that worked for me yesterday didn't work for me today.
And how do you know?
Yeah, and that's one of the biggest problems, is you don't know.
There's a lack of innovation in that space, though. I think people are doing lots of different ways to detect things, but basically what you're describing, if I were to expand on your idea and then take that to diagnostic, get the poop in a cup or on a paper towel and then stick it somewhere, not everyone wants to do that. Actually, nobody wants to do that. So there needs to be some innovation in not just in collection as well, to the point of saliva is a good source, urine is a good source, blood obviously has been a great source for a long time. We need some innovations in the collection space too.
The only problem with blood is that you need a phlebotomist to take the blood out, whereas saliva you can just drool into a tube or urinate into a tube or something like that. It's much easier to capture, and you don't need to pay a phlebotomist to do it or something like that. I think it's very, very important. And we're also changing almost every day. We go to a different restaurant each night or something like that, and we end up, our microbiome changes all the time and things like that. So that's the problem, is we're not even standing still. We're changing damn near every day. And that's pretty much a scary thing.
Any other questions from the audience before we wrap up here?
Can I also make a comment? Sorry, on the self-diagnosis, just always keep in mind that all of us in this room are working a lot with healthcare and diseases and have a specific attention. Sometimes and so could be more inclined to think that people really need to be extra diagnosed, really want to be always checked. Now, if you look at compliance of screening programs, where screening programs are in place, it is for disease that can be lethal, and there are letters sent to people, go and get screened, and if you look at the compliance rates, sometimes it's very, very disappointing. So always keep in mind that we in the room may not be the right audience for self-checking. We have a lot of exposure to disease and a lot of information on disease. People doing different jobs and they have a different opinion.
And yet, if you have type 1 diabetes, would you rather have a continuous glucose monitor giving you your blood glucose at that time, or do you want to stick your finger 6 to 10 times a day? And the question is, with that data now in the cloud, where's the privacy? Where's the HIPAA? And that is the fear of the younger people who have diabetes today, is giving that data up. So, I think privacy at the diagnostic level is an important question. Feel free to
Now, I want to make sure my life insurance company does not see my genome. I think that's important at this point, because I need to know, basically there is a privacy issue. On the other hand, you want your doctor to be able to see everything in your genome so they can basically fix things that are wrong or whatever. But I think with CRISPR and things like that, they can suddenly change everything about your genome and your telomeres and all kinds of things. But I think that's one of the big changes that's happening right now, is that all of a sudden we're now being able to modify our molecular bodies in a very strong way. That's important.
Question?
Do you have any knowledge that any insurance companies are starting to use that sort of testing?
I've heard that insurance companies are asking my doctor for my genome and asking my doctor for my medical records and things like that, and then they might raise my price for life insurance or something like that. So I think that's one of the things we need to do, is we need to have privacy around all the big data that our bodies contain.
But that's going to tumble under the effect of more insurance. You're going to have to turn over your records, right?
And when babies are born, they are now tested for genetic markers. Okay, and who gets that test and what are they being tested for? A whole host of things except HIV. Maybe one of the most important. I think our time is out. I really appreciate the audience participation, and thanks to my panel. Could we give them a round of applause?